Hello, everybody. I see it's Kat here. I see everybody joining. Thank you so much. We're going to give it a couple of minutes for more people to have time to log on and join us. You might all check out the chat function. See if you see my message there and Catherine's message. Hi, Lisa Rigo. Hi, Luke. Hi, Ray. Hi, Tom. Hi, Janelle.
So nice to see all these familiar names.
It is. And that's Dr. Mary McGowan there on the line. We've got Katherine Wilemon, Mary McGowan, and Kat Davis Ahmed all on the line with our wonderful participants. So we'll be, if you want to, we'll wait just a couple more minutes. Everybody on the line is muted with the exception of Dr. McGowan, Katherine, and I, because otherwise we know how crazy these Zoom meetings can get. But we would love to see your comments. It's easier probably if you do it in chat. There is a Q&A function, but the chat function is what I'll be watching, if you can find that. We'd love to see you say hi in the chat function. So great to have you all on. I hope everybody's doing okay. Hi, Eileen. Did I say hi to Luke already? Hi, Kelly Myers.
And Dave, good to see you virtually.
Hi, Dave.
Hey, Terry.
I also see a lot of unfamiliar names, which is wonderful, a bigger group of people in the list of attendees. So that's really exciting. We're so glad to be reaching people. We did this call earlier today, and we're doing it again because we wanted to reach the most amount of people. We know times don't work for everybody. Different times work for different people. So I think we'll just give it just a couple more seconds before we get started. Okay, so my name is Kat Davis Ahmed. I'm the Vice President for Policy and Outreach at the FH Foundation. I also have FH myself, so I am very interested personally in the information that we're covering here today. The reason that the FH Foundation is having this call is that we've heard from people in the community about questions that are really specific to familial hypercholesterolemia and the risk of COVID-19, and also particularly about the treatments that many of us take for FH, and questions that people have and that really need to be answered so that they can continue with the best possible care for their FH while taking the necessary precautions to prevent COVID-19. So it's in response to your questions that we're hearing that we organized this call. And what we're going to do is we'll hear first from Katherine Wilemon, the founder and CEO of the FH Foundation, and then we'll hear from Dr. Mary McGowan. She's the Chief Medical Officer of the FH Foundation and a practicing lipidologist, and we're really just so lucky to have her on board at this really critical time. And as we go, first of all, I'd like to say we're recording this session. Everybody's muted, so I don't think that will be a particular concern in terms of your own privacy, but we wanted to let you know that it is being recorded so that people can watch it if they didn't have the chance at this time. And if you post your questions in the chat function, then if we haven't answered them in the course of the presentation, then we will answer questions at the end of the presentation. And one thing I would like to say is important that obviously this information, this webinar is for your information. The content is not intended to be a substitute for professional medical advice, diagnosis, or treatment, and does not constitute medical or other professional advice. Information, as we all know, is changing constantly and rapidly, and the information on this webinar could be updated or changed. Please follow up with your doctor and medical team for any specific recommendations for you pertaining to the treatment of you or your family. And we encourage everybody to rely on the cdc.gov for the latest update and guidance related to COVID-19. So Katherine Wilemon, founder and CEO of the FH Foundation, I'll hand it over to you.
Thank you, Kat. Hello, everyone. I hope you know that if we know you, we are thinking of you. We are open for business and working harder than ever as a team and an organization to support you individually, to help your families, and as always, to make sure that your voice is heard with the different stakeholders that we work intimately with, and that we help you to get the most up-to-date and accurate information. I think you'll find this presentation by Dr. Mary McGowan exactly that, extremely informative, and we encourage you to jot down your questions as we go so that at the end we can pose those questions to Mary and she will answer them as best she can, with Kat's caveat that some information, as we know, is changing quickly as we learn more about COVID-19. But amidst this unprecedented time in this pandemic, we want to first and foremost reassure you that we are here for you. The most core value of the FH Foundation is a twofold: a deep belief in prevention and also a real adherence to the data, letting the data inform how we proceed. For those of you who may not be as aware of this function, we also do a lot of research. We work closely with researchers around the United States and in some cases more broadly around the world. And so we'll continually try to share with you through our various venues the most up-to-date information. But a lot of research that is not COVID-19 related has been put on hold. And this time for us as an organization does represent unique challenges like it represents for all of us individually. Most nonprofits are also experiencing a very tough time. So we encourage you as you can to be a part of the organization, to volunteer, and to stay in touch and to help us and to donate when possible. But again, prevention comes from being empowered as an individual with information. We feel your vulnerability. Both Kat and I and our families are impacted by familial hypercholesterolemia. I also have some other underlying conditions, and we were on the front end of the wave of saying, if this is a condition that is transmitted by person-to-person proximity, then we closed the physical headquarters of the FH Foundation over 2 weeks ago in an effort, as always, to do our part to contribute to prevention and prevent suffering and illness and even death whenever possible. So I think that a lot of this content was informed by your questions. I hope you'll find it, again, very valuable. I want to introduce Dr. Mary McGowan. She is our Chief Medical Officer. She actually was our very first Chief Medical Officer when we began in 2011, and the first physician to join us officially on the Board of Directors. Our Board of Directors is 50% physicians who specialize in preventive cardiology and lipidology, and 50% individuals who are impacted by FH. And we're so happy. Mary has also been a member of the board, Dr. McGowan, and we're so happy that she is now joined us as our Chief Medical Officer and is just an integral part of our team here at the FH Foundation. She also is a practicing physician at Dartmouth Hitchcock in New Hampshire, and she is on the front lines. Her husband is also a physician, a primary care physician, and we hear from all of our physician colleagues that we work closely with about the heroic sacrifices and efforts that they are making on behalf of the community and people that they serve. So, Mary, I'll hand it over to you.
Thanks so much, Catherine. And welcome to everybody. I think that what we'll talk about today is the coronavirus disease, or COVID-19 in general, and then more specifically talk a little bit about how having FH might in some cases make you more vulnerable to COVID-19 and what we can do to protect ourselves and our family members. So next slide. So just sort of some background. COVID-19 is a single-stranded RNA virus. It is spread primarily from person to person, and it can be spread by asymptomatic carriers, can be spread prior to somebody knowing that they have COVID-19. Sometimes people are shedding the virus for at least a couple of days prior to coming down with it. It's also possible that somebody that has the virus can cough or sneeze and have small droplets land on a surface, whether it be metal or plastic or cardboard, countertops, and that the virus can be spread that way as well. The viral particles enter the lung via droplets. So that is generally how somebody acquires COVID-19. Next slide. So it is a pretty tough little virus. If you come in contact, not just passing somebody on the street, but if you come in contact with somebody with COVID-19, there can be as much as a 30 to 40% transmission. So it is readily transmissible. And the incubation time is quite long. For some people, it's 4 to 15 days. And as I said, you can shed the virus prior to coming down with COVID-19. That's why it's so important to stay at a distance from others. So the viral shedding can occur for 20 days, but it has been as high as 37 days. So it's important to note that viral shedding can occur both before symptoms develop, and that's particularly important since you are feeling well but shedding the virus, and even after symptoms abate. Next slide. So what can you do? So you can really take a lot of measures to stay healthy, and one of them is good hand hygiene. It is amazing how many online tutorials there are. What I'm going to go through, I took directly from the New York Times. This past Sunday, they had multiple photos of all of these things, but it certainly seems a little bit more complex washing your hands than just a quick wash. So you turn on the water, you wet your hands, turn off the water, apply soap, rub vigorously, and this is where your 20 seconds begin. Be sure to get between the fingers, the back of the hands, both thumbs under the nails, fingertips and wrists, then rinse off all the soap. And this is a time when, even though all of us are thinking of the environment, if you use a paper towel, that may be a very reasonable approach, using a clean paper towel and then using that towel to turn off the faucet and then toss the towel. Next slide. Next slide, great. And then, as I mentioned, staying away from others, practicing personal distancing, staying 6 feet away from others, and very importantly, staying at home if you can. It's also important to note that you want to keep yourself healthy during this time. So getting plenty of sleep, even though we're all rather stressed about this, trying to get 8 hours of sleep, eating properly, lots of fruits and vegetables, making sure that you exercise, even if you're not able to go to your gym now, which you aren't, taking a walk, or walking around your backyard if you have one. So jumping rope, staying physically active in the house. So those are some of the things, and being in contact with your family, even if it's virtually, calling them on the phone, texting people to make sure that they're doing well. Cleaning high-touch surfaces daily with wipes or soap and water. And these include things like doorknobs, light switches, refrigerator and microwave doors, drawer pulls, TV remotes, countertops and tabletops, toilets, faucets, and also your cell phone. Next slide. So what are the symptoms of COVID-19? Almost everybody will develop a cough, so that's 80% of people develop cough. A fever is often present at presentation 45% of the time, but even more so over some course of the illness, so 80% at some point in the illness. Being short of breath is common 40% of the time. Upper respiratory symptoms, things like a runny nose, head cold, is a little bit less common in 20% of people. And GI symptoms, while they occur, are only being seen in 10% of people. Nausea, diarrhea, that kind of thing, abdominal pain. Next slide. So how do you get tested for COVID-19? If you have symptoms that are suggestive, the things that I just talked about, cough, shortness of breath, fever, you would want to call your healthcare provider for advice on getting tested. The big issue is you don't want to just present yourself to a healthcare facility. Often, and I know particularly where I'm practicing at Dartmouth, we are beginning to set up drive-by testing so that you're not going in and if you have the infection infecting others. So sometimes testing continues to be difficult to come by, but it is getting better. And you may be asked to go to a specific location for drive-by testing, or a specific location where you can be in a private room before being tested. If you don't have a healthcare provider, you can call, or probably better yet, go online to your state health department and they will let you know where you can be tested. Next slide. So what are the risk factors for severe disease? So some of these come from the Centers for Disease Control, particularly the age. There are some places that will say an age greater than 55, but the CDC is saying greater than 65. Having chronic diseases such as kidney or lung disease, having diabetes, high blood pressure or hypertension, already having cardiovascular disease, having human immunodeficiency virus or HIV, and a history of an organ transplant. The use of some biologics that suppress the immune system might make you more susceptible, but importantly, this does not include PCSK9 inhibitors, which I'm sure many people on this call are on, and I will get to those in just one moment. Next slide. This is data from China. So the US experience may be different, but you can see that the older you are, the more deadly the virus. People under the age of 40 have a very low death rate from the virus, but it's very important for people who are under the age of 40 not to be cavalier, to take this seriously, because if they get infected, they could infect others who are older and more vulnerable. You know, people continuously say you don't want to bring it home to your grandmother, and really we don't want to bring it home to anybody. As people age and develop more comorbidities, other issues, health issues, they are more likely to get a more severe infection that would involve pneumonia and the requirement of a ventilator and even death. Next slide. So does having FH make you more vulnerable? And I think that's a very, very important question, and really one of the questions that we heard through the Facebook sites and people contacting Kat and Katherine directly. And so I think that that was one of the reasons we decided to have this call. Just having FH should not make you more vulnerable. But if you have FH and you have underlying heart disease or other risk factors that I mentioned earlier, you are likely at increased risk, as are people with, out FH that have underlying heart disease and other risk factors. So if this is your situation, I would urge you to do your best to minimize contact with others. Enlist your friends and family to buy your groceries and drop them off, or use a grocery delivery service. It's crucial to continue to take your medicines, but if you've run out, having a friend or family pick them up for you, or using a mail order pharmacy, all important. And stay at home if at all possible. People that have familial hypercholesterolemia tend to have more doctor's appointments. And it's important to ask your doctor if he or she has a telehealth option. I can tell you that everything is moving in that direction. That we are at Dartmouth anyway, minimizing all outpatient appointments. I'm doing my lipid clinic virtually these days. And so it is important to call and ask if that's an option for you. Next slide. One of the questions that has come up as well is, should I stop any of my treatments? There are some theories out there, and I'd like to talk about those. But the first one is, will my center continue lipoprotein apheresis? I can tell you at Dartmouth, we're continuing apheresis, and we are not halting patients from coming in for apheresis. We are asking that people come in by themselves. Often people bring friends and family to their apheresis program because it is 2 or 3 hours, but we are asking people to come alone to minimize contact. Every apheresis center is going to be a little bit different. I've heard from some people that their appointments are being changed a little bit so that there are not as many people getting apheresis at the same time. And so that you may find that there is some disruption. The next questions, should I continue ACE inhibitors or ARBs? These are blood pressure medications, PCSK9 inhibitors, and statins. And I'd like to go through each one of these in turn. ACE inhibitors and ARBs are blood pressure medicines, and as people age, more people develop hypertension, so there are lots of people with FH that are on an ACE inhibitor or an ARB. Now this slide is a little bit confusing, so I'd like to go through it with you. So ACE inhibitors, for example, like lisinopril, that's a generic ACE inhibitor, or ARBs. ACE inhibitors are angiotensin converting enzyme inhibitors, and ARBs, angiotensin receptor blockers, like losartan. These are blood pressure medicines, and one of their effects is to increase ACE2. ACE2 is angiotensin converting enzyme 2. Coronaviruses bind to their target cells in the lung through angiotensin converting enzyme ACE2, which is expressed in the lungs. So that ACE2 facilitates the uptake of the virus. So ACE2 expression, as I said, is increased in people who are taking ACE inhibitors and ARBs. So theoretically, and this hasn't been proven, but theoretically, treatment with an ACE inhibitor or an ARB could facilitate uptake of the virus. Now, there's another side to this. However, once a person is infected with the coronavirus, ACE2 expression decreases and can lead to more severe pulmonary infections. So theoretically, the treatment with ACE inhibitors and ARBs could protect against severe pulmonary infections. Next slide. So it's kind of like the good side and the bad side. So having more ACE2 could lead to increased susceptibility to viral entry into the lungs. But having more ACE2 could be helpful in minimizing the severity of pulmonary infections. And these are theoretical things. So the University of Minnesota has developed a test or a clinical trial to evaluate losartan, which is an ARB, versus placebo in persons with COVID-19 diagnosis who don't require hospitalization. So these are outpatients who are testing positive for COVID-19. At the point of testing positive, they're randomized to either receive losartan or placebo, and they will be followed for the need for going into the hospital, the development of shortness of breath, the ability to perform daily activities, fever on days 3, 5, 7, and 10, and severity of symptoms if a patient becomes hospitalized. So we will have lots more information over time, but I think it's important to listen to the specific societies that are making guidelines on recommendations in terms of whether or not people should discontinue ACE inhibitors or ARBs. And remember, they're being used for your blood pressure, so that's protecting you and protecting your heart. So the American Heart Association and the American College of Cardiology do recommend continuation of angiotensin converting enzyme inhibitors or ACE inhibitors and angiotensin receptor blockers or ARBs. So I would say it's important to follow these consensus recommendations. Next slide. So monoclonal antibodies, of which the PCSK9 inhibitors are one. So monoclonal antibodies are large molecules that bind to specific targets, often on the immune system, aimed at treating immunopathological conditions. Some monoclonal antibodies do have the potential for immunotoxicity. They have the potential for immune suppression or immune stimulation and even hypersensitivity reactions. But this is not the case with PCSK9 inhibitors. Next slide. So what about PCSK9 inhibitors? There's already been some research in terms of the effects of PCSK9 inhibitors. Researchers at the Karolinska Institute in Stockholm, Sweden, which is a very known and notable research institute, have documented that PCSK9 inhibitors can have a positive impact on the immune system. So we know that persons with atherosclerosis have oxidized LDL, and that is a form of LDL that is highly atherogenic, can get into the artery walls quite easily. But that oxidized LDL can also activate certain immune cells, such as dendritic cells and T cells, and that is not good. PCSK9 inhibitors were shown to inhibit this process, inhibit the process by which oxidized LDL can activate these immune cells, so leading to an anti-inflammatory state. Next slide. So the researchers hypothesized that PCSK9 inhibitors may protect against atherosclerosis, both by lowering LDL and by positively impacting the immune system. So it's also notable that statins also have anti-inflammatory properties and immune modulatory roles in addition to their LDL lowering effects. So the bottom line is PCSK9 inhibitors may actually positively impact the immune system. Next slide. So we did reach out to both Amgen and Regeneron, the makers of the two PCSK9 inhibitors that are on the market in the United States. Amgen makes evolocumab and Regeneron makes alirocumab. And what Amgen sent to us is that with regard to PCSK9 inhibitors such as evolocumab, there's no information on the incidence and impact on the risk of contracting COVID-19. But as I've just pointed out, evolocumab is a fully human monoclonal antibody that inhibits the interaction between the enzyme proprotein convertase subtilisin kexin type 9, or PCSK9, which is an enzyme, a protein, and LDL lipoprotein receptors. And it results in increased LDL receptors and lower LDL. There have been over 27,000 patients studied across the Amgen clinical trials, and many of these out to 5 years now. Results from the phase 2, 3, and open label extension studies did not find any risk, any safety risk of immunosuppressive effects in patients receiving evolocumab, which you may know as Repatha. It's always important to consult your healthcare provider, but there is really no evidence that the PCSK9 inhibitors would have a negative effect on the immune system or suppress your immune system. The evidence is to the contrary. Next slide. And Regeneron sent this to us, that PCSK9 inhibitors are monoclonal antibodies. As we talked about, the mechanism, through this mechanism of binding PCSK9 on the liver, they increase the number of functioning LDL receptors and decrease LDL cholesterol. So this pathway is completely separated from the body's negative immune response. It may have some positive immune effects. And Regeneron has studied over 30,000 patients, observed for as long as 5 years, over 25 trials. So sometimes people have reported influenza or flu-like symptoms with PCSK9 inhibitors. And in the studies, these did occur at a higher rate than placebo. And so but the influenza diagnosis was based on symptoms, and in most cases were not confirmed by a flu test. In the Odyssey clinical study program, all of the cases with Praluent or alirocumab were mild or moderate intensity, and more commonly seen within the first 6 to 12 months of therapy. So what I would say here is, if you are one of the people who, when you give yourself your injection every 2 weeks, you get some aching or flu-like symptoms, remember that, know what your symptoms are. And if you were to experience that immediately following an injection, I think you don't need to just jump to, I have COVID-19, if this is something that you have commonly experienced. And what I would say is, this is probably not associated with fever. And so if you've developed a cough and shortness of breath and a fever, and that's very different than something you might have had when you took your PCSK9 injection, then you need to be checked. But if it's just your typical reaction, it's probably just that. And again, there's no data available on COVID-19 transmission or on COVID-19 patients, but there's no evidence that Praluent or alirocumab would have any impact on the risk of transmission or contraction of COVID-19 illness. And we are going to put these statements out on our blog tomorrow. Next slide. What about statins and the COVID-19 infection? Statins are known to have many positive attributes, including, as I mentioned earlier, anti-inflammatory effects, positive immunomodulatory effects, antioxidant effects, improvement in endothelial function. The endothelial cells are the cells that line our arteries, including our heart arteries. So they improve the endothelial function, and antithrombotic effects, so anti-clotting effects. Based on these benefits, some hospitals, in fact, lots of hospitals, are developing protocols for treating hospitalized patients with COVID-19, and they include initiation of statin therapy in these patients, unless the person is found to have liver function tests generally 3 times the upper limit of normal. Next slide. So there are not any currently approved treatments for COVID-19. We do not have a vaccine. As I'll talk about, have some experimental treatments, but we want people to know that the treatments that are available are really supportive treatments. So Tylenol, if a person develops a fever. And I would just point out that I did not put down ibuprofen here. Ibuprofen, like ACE inhibitors and ARBs, increases that ACE2 and might be able to facilitate the entry of the virus. So ibuprofen has an alternative, and ibuprofen does not lower blood pressure. In fact, in some cases, it can raise blood pressure. So if you were to develop a fever and you think that you may be infected with COVID-19, my recommendation would be that we utilize Tylenol. Oxygen is used for patients both at home and hospitalized with COVID-19 if they have decreased oxygen in their blood or hypoxia. Antibiotics are used if there's a suspicion that a person has a bacterial infection or bacterial pneumonia on top of the COVID-19 viral pneumonia. So sometimes when a person gets infected with a viral pneumonia, they can get what we call super infected with a bacterial pneumonia. And so you want to treat the bacterial pneumonia with antibiotics. And if a patient develops more severe respiratory distress, ventilator support may be needed. And next slide. So there are some experimental therapies, and I think it's really important to give credit to the World Health Organization and researchers who are collaborating all over the world. Researchers in the United States collaborating with researchers in Europe, in China, and trying to move things forward. While we do not have a vaccine, we may be able to get some early indications of medications that might work. And some of these you may have heard of, and some of them you may not have. The World Health Organization very quickly has launched a study called Solidarity, and it's using a cocktail of drugs, and we'll talk about those drugs in a moment. But if a person is hospitalized with a confirmed case of COVID-19, their physician can have the patient sign an informed consent and go to the World Health Organization website and mark down which drugs are available at that physician's hospital. The website then randomizes the patient to an available drug, and if none are available, they randomize the patient to the local standard of care. The physician then subsequently records the day the patient gets discharged from the hospital, or sadly, if the patient passes away, records the date that the patient died, records whether or not oxygen was needed during the hospitalization and whether a ventilator was required. The first drugs that are options are hydroxychloroquine and chloroquine. These are anti-malarial drugs, and you've probably heard about them because they have gotten some press lately that have antiviral activity. Remdesivir is an experimental antiviral which was actually used unsuccessfully in the Ebola outbreak. And this agent shuts down viral replication. There have been 2 or 3 anecdotal reports of remdesivir being given to patients with COVID-19 with exceptional turnaround and improvement. So that is a drug made by Gilead that is on, is a possibility for this stuff, for this study. And then lopinavir and ritonavir are protease inhibitors that are used in HIV. Lopinavir does not hang around long, and so ritonavir is another protease inhibitor that allows lopinavir to hang around longer and work. So these 2 drugs can be given as one of the cocktails in this study, or those 2 drugs can be used in conjunction with interferon beta, which is an immune system messenger that can cripple viruses. So these are all experimental and being used in hospitalized patients. Next slide. So I'm going to turn it over to Kat to talk a little bit about telehealth and a few other issues.
Thank you so much, Dr. McGowan. I think that's really incredible, and you covered so much ground that I think is so helpful and specific for people with FH and with heart disease. And of course, everybody will take this information, and if you have specific concerns, address them to your own physicians and other healthcare providers. I know many people see great nurse practitioners and other kinds of healthcare providers for their FH and other issues. What I wanted to point out is that the Centers for Medicare and Medicaid Services, CMS, that oversees Medicare and Medicaid, they changed their rules early in March so that telemedicine could be covered. And that was a really tremendous development and very helpful potentially for people. So we wanted to make sure that everybody is aware of that as a potential option. What we would also like to point out, though, is that while, of course, any decision that CMS makes can influence the commercial insurance or the private insurance market if you have insurance through your employer or through an exchange, but it is not necessarily taken up by commercial insurance plans. So we just want to flag that for you. Many plans have waived copay and prior authorization requirements for COVID testing and treatment. But you should certainly check with your insurance provider, especially if you need to go out of network. Of course, I know it sounds ridiculous if you don't feel that you have time to check, but if you do have time to check, it's important to do that so you don't get surprise bills. Many, but not all insurance plans are covering telehealth for any reason beyond COVID, but again, not all, and some have their own platform, so they would require you to do telehealth through their own physician network or their own, you call the insurance company and they have people for you to talk to, nurses, for example. So please check with your insurer before you go ahead and have those appointments, just to make sure that they're covered and you don't get a bill later that you're not expecting. Many plans are allowing for a 90-day supply of prescription, some by mail, some with early refills. That can be tremendously important, because I think really that Dr. McGowan's conclusion for all of those treatments that you may be on for your FH or for high blood pressure, the message is to keep taking them, and you don't want to miss those doses. But check again with your plan before you order a 90-day supply to make sure that it's going to be covered. And we wanted to let you know that, as always, we're out there advocating for you in any way we can. There are over 200 organizations, including the FH Foundation, across the different diseases, signed on to a letter asking insurers to allow for flexibility at this time, including the 90-day refills, off formulary prescriptions if maybe there's a shortage in the prescription that you take that is on the list of drugs that the insurance company covers, and to ensure that prior authorization requirements don't get in the way of access to care. And of course, we wish that were the case always, but it is particularly important now. And so we've signed on to that letter, and we hope that that kind of advocacy will make a difference for all of us. So I think, Dr. McGowan, that you covered a lot of the questions that people have. And so we wanted, and people have been posting their questions also. So I wanted to make sure that we do address them. I think you addressed the question that we'd heard on in the discussion group before, are you more susceptible to catching COVID because you have FH? And you said no, but are you higher risk for getting sicker if you have heart disease due to COVID? And one of the questions was, what is it that makes a person with heart disease more vulnerable for what we think of as a respiratory disease? Maybe you could answer that.
Yeah, that's a very good question, Kat. And so, as you know, COVID-19 can cause severe pneumonia, and this may reduce oxygen in the blood or cause hypoxia. And that in turn impacts the heart. If the heart doesn't get the oxygen it needs, it can't function properly. And in somebody with already compromised heart, an already compromised heart from having had heart disease, this can cause further damage. There are also some other theories. Some researchers believe that COVID-19 can also cause microvascular damage to the heart. And additionally, there's some lines of evidence that suggest that severe body-wide inflammation can damage the heart. And so again, in both of those latter two, if somebody already has underlying heart disease and they get this second hit, it can make things worse versus somebody who's 20 years old and has never had a cardiovascular event. They may be able to withstand a first hit, so to speak. So that the main issue, though, would be that hypoxia robs the heart of the oxygen it needs to function properly.
Terrific. And I think maybe in the spirit of sharing information regarding apheresis, I would call on people to please continue to share your experiences with us. I think we need more information about what is happening in different apheresis centers across the country. So one person shared that the director of the lab where he gets his apheresis said to continue to go for those treatments because a trip to the ER right now would not be good. And so keep going for apheresis. Whereas another person had posted earlier a concern about going to apheresis where the procedure is monitored by a traveling nurse who visits many hospitals each week. So I think that people's experiences are quite different across different apheresis centers. It's such an important treatment for many people with FH and with heart disease and even beyond FH with high cholesterol. So we have reached out to Konica for more information, and I know they'll get back to us and we'll share that on our website. But I think this is a case where we would love to hear more from the community about what you're seeing, what you're experiencing, so we can share that across sites, across individuals. The other question that people are asking is about, how long the virus lasts. And one person asked if the virus can be transmitted during the full 20 to 37 days. And maybe, Dr. McGowan, you could explain what you mean by viral shedding, just in case we're not all understanding that.
Yeah, so, my understanding is that generally speaking, for a few days, a couple of days before you come down with the virus, if you cough, you can spread the virus. So that is certainly a concern because you're not aware that you have it. So that is one way to spread. That's why keeping that 6 foot of a distance, the droplets may not get to you from somebody coughing. The other issue is that you can shed the virus, still coughing, aerosolize the virus until after you feel better. So the data that I have seen is that the longest length of time that somebody has been found to continue to shed virus has been about 37 days. So that would mean after your symptoms, you can still infect other people. So it would be really important to get a negative test, I believe.
Okay. And by shed, you mean like a dog sheds, like if you're leaving the virus everywhere you go.
Well, you're only in your secretions. So if you're coughing, and that cough, the secretions land on something steel or something plastic, the New England Journal of Medicine has reported that the virus can live as long as 72 hours on steel and plastic, shorter period of time on cardboard, like 24 hours. But those are, again, reasons to really wipe down with soap and water or with alcohol-based treatments, wipe things down in your house on a daily basis.
Okay.
Or more.
And we had one question about when it says that the World Health Organization is randomizing patients to available drug therapy. Does that mean that some people will be on placebo or using standard of care?
Right. So standard of care in the Solidarity trial would only be used if the hospital that the person is in doesn't have access to any of those 4 treatment options. Most hospitals will have at least the hydroxychloroquine and chloroquine, the antimalarials. The Gilead agent that failed in Ebola, I don't know what's happening if Gilead is trying to get that out to others. And then the protease inhibitors that are used for HIV, those should be fairly widely available. So in most cases, hospitals will have access. No, there is nobody getting placebo. You will be randomized to one of those 4 treatments. And they recognize that not having a placebo is not as rigorous a clinical trial, but in this heightened state of concern, the hope is that everybody gets an active drug, and that is what this study is providing.
Okay, and certainly people would be getting standard of care. We also have another question about beta blockers, if they have the same considerations as the ACEs and the ARBs.
Excellent question. So other blood pressure medications such as beta blockers or calcium channel blockers or diuretics would not have the impact of increasing ACE2.
Okay. Okay, I think a terrific question to wrap up the question period with, as we run out of our time together, is presuming that one might contract the coronavirus, what suggestions would you have for what someone with FH should tell doctors about having FH or having heart disease or other risk factors such as diabetes? What should we be communicating to, as we know, not all healthcare providers are fully versed in FH. You might see a young person with coronavirus and maybe not fully understand or appreciate the higher risk. So what do you suggest that people communicate to the healthcare provider if they do contract COVID-19?
Yeah, I think it's very important to be prepared to provide your past medical history, because you might be going to an emergency room that's not your local emergency room. And so it would be worthwhile, I think, to have it written down what your past medical history is. As I mentioned, if you're 30 years old and have FH and have never had a cardiovascular event, it's still important to tell the ER physician or ER health practitioner that you have familial hypercholesterolemia. But I think it's most important if somebody has familial hypercholesterolemia and has already had a cardiovascular event. Absolutely crucial to make sure that the physicians are aware of that. So too, aware of whether or not you have diabetes or high blood pressure. Those things all increase the risk. Chronic kidney disease, and any other underlying disease that might make you more vulnerable. And so I think you know, if you're afraid you won't remember all of that when you go into the emergency room, you know, it's a stressful time, it might be worthwhile to just write something down so that if you do have to go into the emergency room, and hopefully nobody on this call will, but that you have that available to you.
Thank you. Well, I hate to end on that note. So why don't we say that I certainly hope that either it's the case that you find yourself at home with your family and maybe some time and motivation to think about your own health and well-being and that of others, and that you might be looking for ways to get involved with the FH Foundation. Or of course, we all hope that as soon as possible we can return to some new normal. And so we wanted to share the ways in which you might consider getting involved with the FH Foundation if you are not already. And I think really important right now is if you would share FH Foundation resources with your friends and family. We know, and I'm going to give Katherine a few minutes to wrap up. At the end, I'm sure she'll say more, but you know, it's for people like us and the people that we love who do have heart disease caused by FH, that we're asking people to stay home and protect and slow the progression of COVID-19 in our population. And likewise, for the healthcare professionals who take care of us on a daily basis and may have now been asked to move sort of to the front lines in the ER and take care of people with COVID-19. So share the resources of the FH Foundation. We have some great resources related specifically to COVID-19. Share those with your friends and family and help them understand that it's for you and the people that you love, that we're all people like us, that we're staying home. Join our online discussion groups if you haven't already. You can find them, a link to them on our website, or search us on Facebook or email us to get the information. Share your story with the FH Foundation. As Katherine said earlier, I think some of our activities about raising awareness of FH may have to take a back seat to COVID-19 at the moment, but we still want to hear your story and get to know you, and there will be a day when it's time to share those stories again. There are lots of ways you could volunteer with the FH Foundation, and we would love to share those ideas with you if you find yourself with the capacity to do that. And you know, even at this time, to consider making a donation to the FH Foundation.
You know, Kat, I think that that's a really important point. At this point in time, due to COVID-19, we are having to cut back on lots of the fundraising that we would have been doing, and also, you know, corporations that might have had the funds to sponsor us in the past seem to not be able to quite as easily. And so if people value the kind of support that they get from the FH Foundation, this is a time that the FH Foundation really needs your support as well. So if you can, it will be wonderful.
So Katherine, I've left you 2 minutes to wrap up. Thank you.
Dr. McGowan and Kat, thank you so much. I know that everyone found that incredibly valuable. It's the second time that I've gotten to hear it today. And Dr. McGowan, you did such a fantastic job of educating us all about what we can do about COVID-19 and how at risk we are or aren't. And I think really for the FH Foundation, again, a core value of ours, and it is not as ubiquitous as you might think, is to invest in and commit to prevention. All of us on the team dedicate our lives to helping others and bringing the knowledge to individuals that they would need to be able to help themselves and help their families and help people that perhaps they have never met. And so our commitment is always to prevent the onset of illness rather than to reacting to the disease. And hopefully we are a model for other conditions in that. And this pandemic gives us all the opportunity to demonstrate our willingness, the willingness to do what it takes to protect ourselves, to take self-responsibility for educating ourselves and following medical recommendations and public health recommendations, and to help protect others from all the physicians that we hear and public health folks that we're in constant conversation with. I hope you will all err on the side of staying home, because that is the best way to prevent, that we know of at this time, the spread of COVID-19, and to protect yourself and the family that you love, again, as well as others. As individuals with FH, I'll just close on this point. As individuals with FH, we know intimately what it is like to feel vulnerable to a disease, to even feel threatened, to feel what it's like to be afraid of death. And we know what it's like to be sick and have a disease process going on in ourselves. Some of us know. I have heart disease, even though we don't look ill. And so I think it's an opportunity for leadership from our community. So, but the good news is that I think we can do this together, and that many of us will come through wiser and even more committed to what really matters in life. So thank you all for being a part of this community, for being a part of this organization. We send you light and love, and hope that you will stay well and stay in touch.
Thank you, everybody.
Thank you.